everyone. I'm Gretchen Von Allmen. I'm the director of the UT Pediatric Epilepsy Program, and I work at Children's Memorial Hermann Hospital and UTHealth at McGovern Medical School. This is just some of the buildings at UTHealth and Children's Memorial Hospital, where our clinics are held, and also where we evaluate patients who have epilepsy in the hospital. So first of all, what is epilepsy? Really, epilepsy is a word that just means that a patient has had 2 or more unprovoked seizures. And a seizure is defined as a clinical event that's caused by a synchronized electrical activity in the brain. And so really all epilepsy means is that a person is prone to have seizures because of this abnormal electrical activity in the brain. And the way each person's seizures look, or sometimes people can have several different types of seizures, the way that seizure looks or the clinical presentation really depends on where the seizure is happening in the brain or where that electrical activity is occurring that's abnormal. And you can see here, this is a picture of the brain. And this is the front of the brain and the back of the brain. And really, it takes about 10 square centimeters of brain tissue that's firing abnormally in order to see that reflected on the EEG, which is the brainwave test that we do that helps us understand a person's epilepsy. And it just goes to show you that there's a fair amount of brain that's acting abnormally when you see that abnormal electrical activity reflected on the EEG tracing. And depending on which part of the brain is involved, sometimes it's the whole brain at once, and sometimes it's just one focal area of the brain that's starting the seizure out. You can have different manifestations when the person has the seizure. So it can be anything from just staring and not responding to moving an arm or a leg that's typically the same every time. And you can see here on the bottom right picture that this is called the homunculus, and it's a demonstration of how the body is based in the brain tissue in terms of activity. So there's a part of the brain that controls movement of the opposite side of the body, and different areas in that region are going to be in charge of moving the face versus the hand versus the leg and so forth. So depending on where the seizure is starting in the brain, you may have different clinical features that you see in terms of the behavior of the person having the seizure. We also call that semiology, which is a description of the way the seizure looks when the person is having the seizure. So just to talk a little bit about epilepsy in the United States, this is from a study that was done in 2011 by the Institute of Medicine. And it really shows that the age of people who have epilepsy, and there are 2.2 million people in the United States, and probably more at this time, who have epilepsy. You can see that the highest incidence or number of people who have it by age is the highest in people who are very early in life, so in the first year of life. And then, you see epilepsy occurring in children under 10, and then a little bit less in people aged 10 to 20 years old. And then as you get to adulthood, you see a decrease in the incidence of epilepsy that's starting. And then as the person gets older, they can also start to have epilepsy, often due to strokes or, brain injuries that happen later in life. And it turns out that about 1 in 26 people are going to develop epilepsy in their lifetime. So that's a very common problem. And I think there's a lot of times where people just don't realize how common epilepsy really is. So the highest incidence of epilepsy occurs in children who are less than 15 years old and adults over 65 years old. So there are about 3 million Americans who have epilepsy in the US, and there are about 6 million children in Texas who have epilepsy. About, there are about 6,000 people in the city of Houston and 18,000 in the greater Houston area who are children who have epilepsy. And about a third of those children, and this is also true for adults, about a third of adults and children with epilepsy are what we call intractable, meaning they don't respond well to medication. We'll talk about that more in a second. So there are several different types of seizures, and this is based on the description of what the seizure looks like when the person has it. And you can either have a generalized seizure that is starting on both sides of the brain at once and manifests as a convulsion where the whole body is shaking. And there are several different types of convulsive seizures. There's a tonic-clonic seizure, which involves the whole body being stiff and then shaking more or less rhythmically. You can have just a tonic seizure, which is where the body just gets stiff. And then myoclonic seizures, where there's a whole body jump or a startle, usually involving the arms more than the rest of the body. And then there's also non-convulsive generalized seizures, which are mostly absence seizures and atonic seizures. An absence seizure just means that they're staring and arrest of behavior for this particular type of seizure. And then atonic means the body loses tone. So the muscle tone goes away and you have a drop of the head, or the whole body can drop. Focal seizures really mean that the seizure is starting in one part of the brain and then sometimes spreading to other parts of the brain. So you can have a motor seizure, which means you're having movement with the seizure and it's in an area of the brain, like we talked about before, that is associated with movement of the body. You can also have a hypomotor seizure that's focal, meaning you don't move at all or you kind of freeze. And that is also because of the part of the brain that's involved. And then there's another type of focal seizure called a dyscognitive seizure, which sometimes looks a lot like the non-convulsive or absence type of seizure, but it's actually just occurring in one part of the brain as opposed to the whole brain. And we call dyscognitive seizures that way because, it might mean that the patient is just not aware of what's going on or is confused, or they have problems talking, or have something else that just happens for a short period of time, and then they may return to normal or be tired afterwards. There are multiple different causes of epilepsy in children, including structural reasons. So in the brain, you can have a brain malformation that happens before the time of birth. You can have an injury at birth or a stroke. Trauma can cause epilepsy and also tumors. And then there are a lot of genetic causes of epilepsy that are either inherited or there's a mistake that happens in the genetic code in just that individual. So, during development of the fetus, you have this genetic cause of epilepsy that just happens in that one child. You can also have causes that are metabolic, meaning there's an inborn error in metabolism. It also is usually something that has occurred before the child is born, but may manifest at different times in childhood. And thyroid disease and various vitamin deficiencies like pyridoxine deficiency or B6 deficiency, for example, can also be part of this group that can cause seizures and epilepsy and may have a different treatment than the other causes of epilepsy. And then there are also infections of the brain and autoimmune problems that can cause epilepsy, including meningitis and encephalitis. So what happens when a person is being evaluated for seizures or epilepsy? Really, the first thing that happens is a child or adult should be seen at the clinic, an epilepsy clinic preferably, or the neurologist. And a history is taken, so exactly what the seizures look like when they occur, whether there are any triggers to the seizures or things that happen that seem to provoke the seizure to happen at that time. And then also the examination of the patient. So if there's anything that is a clue that there's something going on in the brain, or especially something focal that's abnormal, in the neurological exam. That can also be a clue as to what's causing the seizures to happen. So the main test that we do once someone has visited the clinic and had a history and exam done is an EEG, and that's an electroencephalogram. And these days that's usually done with a video running at the same time so we can see what the person is doing or what the child is doing. And there are a variety of different EEG tests that might be ordered when you first see a doctor for epilepsy or seizures. It can be a routine, which is a short test that takes 20 or 30 minutes to do. It can be an ambulatory EEG, which usually the equipment is, put on the head and taken home. And for a few days, usually that test is done at home versus in the hospital where someone might come in just for a day that's scheduled to have an overnight EEG, or for several days where they're admitted to the hospital for a continuous EEG. And, there are a number of hours that might be ordered by your doctor for the evaluation, from 24 to 72 hours. And these various different types of EEGs might be ordered. And the one that is ordered, might be based on how often the episodes are happening, or other factors that your doctor uses to choose what type of test is ordered. And then brain imaging is usually one of the first things that's done also. Usually these days we use an MRI scan because it's a more detailed picture of the brain structure. And if there's an abnormality in the brain structure, that can give a reason why epilepsy is happening in that child or adult. And sometimes a CT scan is done if you go to the emergency room or that kind of thing. And CTs are really best at looking for like tumors or something, a little bit more obvious, like a stroke or some other injury to the brain, like bleeding in the brain. And the MRI is better at picking out more subtle changes that might have even happened before the child was born and affected brain development. The other thing that's often done is laboratory testing and genetic testing that could be a combination of, a blood draw, saliva, or, even a cheek swab, or, sometimes spinal fluid where the patient has a spinal tap, usually done at the hospital or in a procedure room. And then if the doctor feels that these episodes are seizures and represent epilepsy, then often a medication trial is started with an anticonvulsant drug. And we have 20 or 30 drugs that can be used for epilepsy, and the choice of which one is the first drug to try, it really just depends on that particular patient and what type of seizures are happening and what type of epilepsy the doctor thinks this might be. Can change what medication might be chosen first or might be thought to work best. And sometimes the EEG is also helpful in making sure that the medication is going to be the one most likely to help with controlling the seizures. So I'm just going to go through a few different types of seizures that children can have. Probably the most common one, and this does not necessarily mean that the child has epilepsy in this case, but febrile seizures are very common in children who are less than 5 years old, between infants and 5 years old. And it occurs in about 2 to 5% of the population. Simple febrile seizures are most of the things that are seen. And a simple febrile seizure just means that there's an illness or a fever in the child, and at that time a seizure happens, usually a convulsive seizure that just lasts 1 to 2 minutes and stops on its own. So some of the things that can make febrile seizures more likely to happen in someone who's already maybe prone to have those is, going to daycare, because they're exposed to a lot of viruses and illnesses at daycare, and so they tend to get sick and have febrile illnesses, and that can, provoke a seizure in those patients, or patients who have developmental delay. And then also people who have relatives who've had febrile seizures when they were children. And about 10% of the time, the child who's had a febrile seizure will have a sibling or a relative who has had febrile seizures as well. And then also if there have been complications at birth requiring the baby to stay in the hospital for, the first month of life, for example, can sometimes increase the risk of febrile seizures happening. Really, if you have, the more of these risk factors you have, the more likely it is that you might have a febrile seizure. So if you're going to have more than one of these, often the person is less than 18 months old and may have a family history of epilepsy or febrile seizures. And if you tend to have a shorter duration that the fever is happening before the seizure occurs, then those people are more likely to have another one. And, if the seizure occurs at a lower temperature of fever, then it may be more likely to happen again. Most of the time, febrile seizures are not treated with seizure medications or anti-epileptic drugs because it's not thought to really help control those. Really, the best way to control those is to not have febrile illness and not have a fever, which sometimes is very hard to prevent a child from having. And so in terms of what that means later in life for that child, there's a risk of future epilepsy when you've just had simple febrile seizures of 1 to 2%. And if you have kind of a more complex picture with the febrile seizure and abnormal development neurologically, or a family history of epilepsy, it can increase to 5 to 10% risk of having seizures later in life in epilepsy. So, and then sometimes, we find that febrile seizures are just the start of a type of epilepsy syndrome. And so in childhood absence epilepsy and myoclonic epilepsies and temporal lobe epilepsies, for example, a lot of these different epilepsy syndromes that might be identified later on in the child's life turn out to have febrile seizures as, during infancy. That can be a clue to the type of epilepsy syndrome the child has. But at the time of the first febrile seizure, you may not know whether that means that this is part of an epilepsy syndrome or really just a regular febrile seizure that the child is going to outgrow and not have epilepsy afterwards. So that's a very common way for children to present to a clinic or to their pediatrician or neurologist is with febrile seizures. And then, just so you know, there are some genetic causes of febrile seizures that are involved with sometimes with epilepsy later in life. And, sometimes there are sodium channel genes that are implicated in this. So sometimes if you're having recurrent febrile seizures, your doctor may do genetic testing to see if that's a clue as to what might be coming in the future for that child. Another type of epilepsy that's common is childhood absence epilepsy. And this is a seizure that lasts about 40 to 20 seconds and usually occurs several times in a day, where the patient just stops doing what they're doing. Sometimes they stare, sometimes they have blinking or rhythmic movements of their eyes or face, and then they go back to whatever they were doing right away. And usually there's no what we call aura or warning that the patient can tell you about, or confusion after the seizure or post-ictal confusion. Usually you don't have that with this type of epilepsy. And sometimes you can have myoclonic or jerks of the body. You can have something called automatisms, where there are movements of the hands or fingers. And, so sometimes you can have other things associated with these staring spells. Usually the patient will start to have them between 5 and 8 years old, and children are otherwise healthy, don't have any other medical problems or neurological problems for the most part. And then often, they will have at least one GTC or generalized tonic-clonic convulsive seizure. Okay, so another type of epilepsy that's common in children and in young adults is called juvenile absence epilepsy. This is also a type of epilepsy where you have absence or staring spells that last a little bit longer, 10 to 45 seconds, also usually happen daily. And the EEG findings are also similar to the childhood absence epilepsy. So, and the treatment is going to be similar. Usually it's with medication, which most people are going to respond to if they have these types of epilepsy. Juvenile myoclonic epilepsy is another common epilepsy type where you can have myoclonic seizures, convulsive seizures, and staring or absence seizures. And usually the onset is later in life in these children. So between 12 and 18 years old is when they were usually are going to have their first seizure and be healthy before that. And there are some genetic abnormalities associated with this type of epilepsy syndrome, and about 15 to 50% will have a family history of other family members with this type of epilepsy. So also an EEG is done for this. It has a very specific finding that I'll show you here, and it's called spike and wave discharges. So these kind of sharply contoured waves here that looks like it would be uncomfortable if you had to sit on it, that's a spike, and that's an abnormal kind of sign that happens during a seizure or sometimes in between seizures in these patients. And so this is what we're looking for on EEG that can give us a clue as to what the diagnosis is and what type of epilepsy that patient has. And this is just another look at the EEG. So in terms of other epilepsy syndromes, there's benign epilepsy with centrotemporal spikes or benign orlandic epilepsy. And this is usually a seizure that is happening in one particular area of the brain, but usually involves the mouth, sometimes with drooling or facial numbness. The child is usually otherwise awake during this, and usually it's going to start around 3 years old, all the way up to 13 years old. And usually most children, if they have this type of epilepsy, will have had a seizure by the time they're 8 or 9. It's usually happening when they're going to sleep. And sometimes they're awake, they're aware of what's happening during the seizure. They have preserved consciousness. There's often gargling or drooling and grunting sounds that can happen because the mouth is involved in the seizure. So this type of seizure is sometimes genetic, and the diagnosis is based on the description of the seizures and when they're happening, what age of the child, and then the findings on the EEG also are a clue that this is the type of epilepsy that they have. And then the treatment is with an anticonvulsant medication, usually one that's used for focal epilepsies like oxcarbazepine, levetiracetam, and usually the seizures respond well to medication, and the patient doesn't have any more seizures when they're on medicine. Usually this type of epilepsy is something that kids can grow out of, and so seizures usually resolve within 2 to 4 years of the time they start. And some children may have seizures of other times later in life. This is just an example of what the EEG looks like in benign orlandic epilepsy. So you have what we call focal discharges coming in from a very particular part of the brain. And really the best treatment for epilepsy, regardless of what seizure types you have, is usually anticonvulsant medication. So anticonvulsant medicines are taken every day to prevent seizures. Depending on the medication, it may be once or twice a day, or sometimes even 3 times a day. And there are a lot of different types of medications. Some are better for some types of seizures or some types of epilepsy than others. And so that's why doing the diagnostic testing like the EEG and the MRI can be very helpful in determining which medicine is going to work best. And it's very important to remember as a family member or as a patient who has epilepsy that the goal of treatment should always be to have no seizures and no side effects, or as few side effects as possible. how effective are medications? So often children will respond to the first or the second drug that they're tried on, as long as it was chosen effectively for the type of seizures they're having. So 47% of children and adults will, when they try their first medication, are going to be seizure-free. If they aren't seizure-free with the first medication, then a second drug is usually tried, and about 36% more of the people who try their second drug are going to be 13% are going to be seizure-free with the second drug. Once you get past the second drug, assuming that the type of drug that was chosen is appropriate and the diagnosis is correct, the chances get smaller and smaller that the seizures are going to be well controlled with any of the medications that we have. So once you get past the third or multiple drugs and the patient is still having seizures despite medications, those patients fall into about a third of the whole group, and about a third of patients are not going to respond well to any of the medications that we have, and we call those intractable to medication. A lot of these children, especially who are in the first or second category here, are very possibly going to outgrow their seizures as they get older, especially as they get towards puberty, and they may not need medications over time, but that is going to depend on what type of epilepsy they have and what the cause is of the epilepsy. So if medications don't work, then what? So those third of patients that aren't going to respond to any of the drugs have what we call intractable epilepsy. And so really, once a child or an adult has failed 2 or 3 different medications and continues to have seizures, despite the proper medicine and the proper dosing, the chances that they're going to become seizure-free with trying other medicines after the first 2 or 3 is less than 2% chance. So these patients are very important because we want to try to control their seizures, and there are different things that need to be done once 2 or 3 drugs have not worked. And that's a lot of what we do at our epilepsy center in the hospital and in the clinic. So what are the risks of someone who has persistent seizures despite medications? So they can have a detrimental effect on cognitive and social development for a child, and also their quality of life. There's also a significant risk of something called SUDEP in people who especially don't have well-controlled seizures, and that's sudden unexpected death in epilepsy. It's something definitely worth talking to your doctor or epileptologist about. And it's really something that you want to be aware of because it just outlines the importance of being able to control your seizures and be seizure-free, because that's the best thing to reduce the chance of this sudden unexpected death in epilepsy. And so it happens more often in people who have uncontrolled epilepsy and can continue to have usually compulsive seizures is the highest risk category that aren't controlled with medication. So really, because of all those things, our goal is to control the seizures as soon as we can, and especially in children, this is going to help optimize their cognitive development, their behavioral development, and improve their quality of life. So the types of treatments that are available for people who are in that third of the population of epilepsy patients who don't respond well to medications are several. So we have several different treatments that aren't medications that can be used in people who don't respond well to medicines. And really the point of further evaluation in either what we call the epilepsy monitoring unit or further testing, usually in the hospital, are to see which of these options for treatment are going to be best for that particular patient. So you really want to try to explore those options as soon as possible so that you can use that treatment as soon as possible and prevent further seizures from happening, and kind of as early in the course of the epilepsy as you can, because often the earlier you try these different treatments, the better they work. So there's something called laser ablation, there's epilepsy surgery, there's a vagal nerve stimulator device that can be implanted. There's RNS, which is another implanted device that is a brain stimulation device. And then there's also diet options, mainly the ketogenic diet, which can help control seizures much better than just medications. And this is just kind of something to show you how the different treatments that we have other than medication are going to be successful and how efficacious or effective they are. So the reason focal epilepsy surgery or resective surgery is at the top is because it really gives the patient the best chance at seizure freedom. So about 50 to 90% of patients who have this type of treatment or surgery are going to be seizure free after surgery. And that's really the best outcome we have, other than if you're seizure free on medications. There are other types of epilepsy surgery called a hemispherotomy that can be done, and the other surgery is a corpus callosotomy down here in the middle. Those types of surgeries can also be very effective at stopping seizures. And the corpus callosotomy is kind of in the middle of the group, but it can cause a reduction in seizures of 50 to 60%, especially if the patient is having atonic or drop seizures. The other types of devices that we have, implanted devices, are the RNS or neurophase device, which is implanted in the skull and has electrodes in the brain tissue, and also the vagal nerve stimulator, which is a device that's implanted in the chest and stimulates the vagus nerve that's in the neck, can reduce seizures by 50 to 60% in patients who really aren't responding well to medicine. So you go from the bottom, which is having a 1 to 2% chance of seizure control if you're not responding to medications, to 50 to 60% seizure control or reduction, and then all the way up to 50 to 90% seizure freedom with surgery. So how do we figure out which treatment is going to be best for each patient? And really the way we do this is in our pediatric epilepsy center evaluation. So there are a lot of different details that can help us understand which options might be best for a patient. And there are several different tests that we do to see which options are going to be the best ones. So the prolonged video EEG is something that's done in the epilepsy monitoring unit, where seizures are captured on the EEG and on the video, and so that we can see exactly how that seizure is occurring in the brain and what the manifestations are when the patient has a seizure. And those can help us understand where is the seizure coming from, and is there a seizure focus that you can remove surgically, either with actual brain surgery or laser ablation, for example. And then the MRI, the 3T MRI, gives you just a more detailed picture of the brain and can help us see focal abnormalities that might be more subtle, that occurred during brain development and are still there and can cause epilepsy. And often, if all of these testing reveal a focus that's in the same place in the brain, then you can target that area of the surgery potentially. So that's really one of the main questions that we're trying to answer when we do phase 1 evaluation. These are all non-invasive tests, including the MEG, which we have at UT and Herman Hospital, and can be very helpful in localizing where a seizure or where the epilepsy is starting. This is just what the magnetoencephalography machine looks like. It can work in babies and in adults as well. And most of the time they go to sleep during the recording. And it really this is just to show that the EEG is measuring electrical fields generated by the brain. And that's why electrodes are placed on the brain or on the skull, the scalp surface. And the MEG measures magnetic fields generated by those same brain cells. And it just is able to pick up kind of the manifestation of that abnormal activity in a different way And so sometimes it can see different things than the EEG can see. And that's why we try to get both of them done for patients who might be epilepsy surgery candidates. So they can see different things in the brain. And this red outline might be the part of the brain that's causing the seizure. And so you might need these different tools to really tell which part of the brain is causing the epilepsy to happen. So MEG can help with decision making and decide whether someone might be a surgical candidate or not, along with all the other tests that we do in the phase 1 evaluation. And the good news is don't worry, we're not going to ask you to interpret your own test like this cartoon, but we do something called Have an Epilepsy Case Conference. So every week, the pediatric and adult groups for epilepsy get together and talk about each case that's had a phase 1 evaluation. And we go over with the neurosurgeon and the MEG specialist and all the epilepsy doctors and the radiologists, all of the test results, and we look at them all together and discuss each case one by one and decide what is the best treatment for this particular patient. Is it surgery? If so, do they need another invasive set of tests done, or could they go straight to surgery, and what would be the best surgical approach? And then what are the risks and benefits of those surgical options for this particular patient? And just to remind you, sometimes surgery is thought of as a very scary procedure that should be like the last possible thing you want to try for a patient. But in reality, epilepsy surgery is the most effective treatment that we have for epilepsy. And if a patient is a candidate for it because they have focal epilepsy that we think would be amenable to surgery, it's really the only potential cure for some people who have refractory epilepsy or epilepsy that doesn't respond to medications. And right now, a patient has to fail 7 different medications. Remember, usually we say 2 or more, you're gonna need an evaluation for surgery. So they've already failed 7 on average before anybody even considers surgery as an option or anything besides medicine. And it takes an average of 17 to 20 years in the United States before patients who are candidates for epilepsy surgery actually get to have surgery. So we really want to try to close that gap and make it less time so that people can get to surgery as soon as possible if that's the best option. If it's not the best option, then we see what other non-medication options there are. And so this is just to demonstrate there are a lot of different tools that we might use to see if, there are other options for a patient besides just medicines to make their epilepsy better and better control their seizures. And then really we want to consider all of the options for each patient. It could be surgery, it could be a vagal nerve stimulator, it could even be the ketogenic diet, but each patient deserves this workup and deserves to have better seizure control, as optimal as possible, given what we're able to do in medicine right now. So that's all I have for you guys today. And I just want to say that please, this is our epilepsy team on the pediatric side. We encourage you to call and get an evaluation, and we can do all the things we just discussed in this presentation. And I hope you guys have a great day and a great Epilepsy Awareness Month. Thanks so much.